Welcome to Frame by Frame, Rethink Imaging, a podcast by Radiologist. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. So today on Frame by Frame Rethink Imaging, we are very excited to welcome Dr. Elizabeth Krupinski, a pioneering expert in the psychology of medical imaging. Dr. Krupinski is a professor and vice chair for research in the Department of Radiology and Imaging Sciences at Emory University School of Medicine. With a background in experimental psychology, her research focuses on understanding the cognitive and perceptual mechanisms that influence how radiologists interpret medical images. Today, we will dive into the psychology behind radiologist error, explore the challenges of burnout, and discuss how psychological principles can be applied to improve the accuracy and well-being of radiologists in practice. Welcome, Dr. Krupinski.
Thank you. Good to be here.
Great. It's so good to have you. Now, let's start off. You have an interesting background in experimental psychology. What initially drew you to the intersection of psychology and radiology together?
Pure chance. My background, like you said, is in experimental psychology. And what that means is a whole variety of things to a whole variety of people. But as an undergrad, what it meant was looking literally at the neurobiology of the visual system and at the cellular level and putting electrodes into rats' visual cortex. And that simply did not really appeal to me once I really, got into it. I wanted to do something where I would want to see more of an immediate impact and to see how what I was doing would actually impact people in society. And so when I started to get my master's, I was doing more kind of real world type stuff. And my advisor at the time had his old advisor, actually, and they were looking for someone to come into their lab and work. And in my master's, I was looking at the perception of art and how one person could look at a painting and say, wow, that's amazing. Look at those brush strokes and everything else. And somebody else is saying, it's red. What's the big deal? What features in a painting will make people react one way or another? And I realized then that, if I go down that route, and it's fascinating, it's amazing what leads to people liking art versus someone else saying no. But I realized, I would end up teaching 100% of the time, maybe have my summers off to do research. And really, nobody funds research in the perception of art. And again, back to the impact, I really didn't see how that was going to have a huge impact on society or people. And so I said, yeah, sure, I'll go, interview. It seems like an interesting possibility. And that lab happened to be run by a radiologist and a cognitive psychologist, actually an educational psychologist, who were looking at errors in radiology from that perceptual cognitive point of view. And it was like, okay, this is what I want to do for the rest of my life. Please hire me. And they did. Then I spent 5 years with them, and I also got my PhD. That was at UPenn. I got my PhD at Temple, working in their lab and doing all my research on medical image perception. And so literally it was pure chance, but once I found it and got into that lab, that was it.
That's very funny. I was an art student in college. I actually did my senior thesis was a what's the word? It was like an immersive art piece designed to get people to think about how the space they are in affects the art that they are looking at. So I had traveled around Europe a bunch and noticed where the benches were placed in specific galleries and was curious about how the social dynamics of seats in certain spots affected people's viewership of art and the emphasis put onto different works just based on how people move through the space. So it is funny to be talking to another art to imaging person.
And we all went into different things.
Yeah, absolutely. Beautiful. So, Dr. Krupinski, in your research, you focused on the cognitive and perceptual mechanisms that influence how radiologists interpret medical images. Can you explain just a little bit about that and then how these processes start to contribute to mistakes?
Yeah, take it down to its absolute lowest level. What is looking and interpreting a radiograph? It's looking at a picture and making a decision. So let's take it down all the way down. Now, obviously, it's more complicated than that. But looking at a picture that involves human perception, which has its limitations. We are in our visual systems are influenced by a ton of things. One, our basic wiring. We are limited in the types of things we can see. For example, we don't see ultraviolet or infrared light, yet other animals do. So the information is out there and available, but the way we're wired does not allow us to see those things. We are good at certain things and not good at others. We have a certain dynamic range that we're able to see. And so from the perceptual side, we have, like I said, certain limitations in terms of what we're actually able to extract from the world, and in this case, images, in order to then send that information up to the brain, which is the cognition part, which to some extent has limitations as well. The brain and that eye-brain interface is formed and shaped by our experiences, what we've encountered, the limitations of our visual system and our cognitive systems, biases that we may have, things we've encountered in the past. So our entire history of, radiologists interacting with radiology images and so on, the types of images they see, the type of training they receive, the spectrum of diseases that they've encountered, all of this shapes our ability to perceive images and so on. Put on top of that the fact that our brains don't just click into one thing and that's what you're doing. Other thoughts can intrude as well. So if you're worried about the football game tonight and you're sitting there, who's going to win the national championship, that's kind of in the back of your mind, and every now and then you might kind of wander your thoughts and start thinking about that rather than the task at hand, interpreting an image. Or you might worry about something else, or you may be interrupted. So there's a lot of things that can happen that disrupt the cognitive processes and what you were doing in order to perceive the information in an image and extract it. And that's where errors can occur, when some of these things go wrong. And there's a lot of reasons for errors. And over the years, we've kind of broken them into, sort of three main categories. There's sort of search errors, which if you think about an image, say, with a chest nodule, and you're looking around and you simply don't even look at the target, and it's not big enough to kind of see through your peripheral vision or anything, you simply miss it. You don't look at it. And there's a variety of reasons why that may occur. It may be so small, so well hidden that, it's just out of the realm of what you could see without really dedicated, oh, wow, there it is. But again, you could be distracted and simply not look at that part of the image. And then there are recognition errors where you actually do look at it, but eyes see it, they start to process it, but it doesn't quite hit cognition. The brain doesn't recognize it as, hey, pay attention, something's potentially there. And then there's the third category, which we call cognitive errors, which is you actually look at it, you consider it, and then you say, no, I don't think that's... And we've found this out through eye tracking over the years. But yeah, there's a lot of reasons why errors occur. Like I said, straight from basic biology through just the environment within which we live.
Yeah, well, it's funny. As you were explaining those types of errors, mind immediately went to like a Where's Waldo book, where every page, okay, I need to find Waldo. He may or may not be on this page.
Exactly. Exactly.
Right? It's like he might be there. And so, like, I think I saw a study that was like, here is the optimal eye pattern to, like, try and find Waldo. Thinking about that, but, like, with so much on the line and you're looking at it all day long and you don't know if he's there.
Exactly. And the funny thing is we did a study years and years ago in early 1990s where we looked at radiologists and just lay people from the lab, doing Where's Waldo? And radiologists are no better at finding Waldo than anybody else. So it's not like they're any better, they have this innate capability to find things. They don't. They're like we did Waldo, and they were in fact probably worse than undergraduate students at finding Waldo. So
the radiologists, in fact, were performing less or not performing as well as the grad students at Where's Waldo, which I guess makes me wonder, like, how much does experience play into the fact that radiologists are making mistakes? Like
a little bit, yeah. I mean, we've been able to look at, and we've done this in radiology, we've actually done it in pathology as well, where we've looked at, and every study that I do actually looks at both residents and attendings, because I like to look at how do people with different levels of experience perform at some of these different tasks. And almost always there's differences. And it truly is amazing. We did the study in pathology that we did. We were able to get a cohort of pathology residents right at the beginning, within 1 week of starting their first year of residency. I mean, first week of their second year, first week of their third year, first week of their fourth year. So we were able to get them. And what we did was we ran them on the same set of images. And we tracked their diagnoses and we tracked their eye tracking, how they searched. And we were able to see how expertise evolved as a function of those 4 years in residency. I mean, their search patterns changed, their ability to recognize things, make diagnoses changed. And it literally is, it is something that evolves. And it's a function of the number of images that you're exposed to, the diversity of the images, the types of diseases and so on that you're exposed to. Plus, I mean, obviously, you've got to have some ability to do this. Not everybody who goes into pathology or radiology is actually good at it. And some people leave, and some people are the ones that go to. If it's a chest image and I'm going to Dr. X, and I know that they're like the world's expert in this. And there's other ones where maybe let's go ask somebody. But it is something that evolves over time. It is domain specific. I mean, if our radiologists had spent time looking for Where's Waldo in their spare time, I'm sure they would have been experts at Where's Waldo as well. But it is a skill that evolves, and it is both perceptual and cognitive. Like you said, there's search patterns, like with Waldo. As you gain expertise, there are optimal ways to search, and it may be idiosyncratic to the individual person, but there are ways to make your search efficient and effective and then get that information to the brain, and your brain evolves as well to be able to figure out, yes, that's something, no, that's not something, that's an artifact, or that's just, normal anatomy looking kind of funky.
Right. And so, as radiologists are developing these skill sets, getting better at looking, changing the way that they look, gaining experience, I imagine it helps a lot up to a certain point, but then at what point does overconfidence or fatigue start to cross over with that,
I'm not sure about overconfidence. I mean, I don't think anybody's ever really studied that per se. But fatigue, certainly. Fatigue, burnout, I mean, all of those things. And we've done a number of studies. We had about 10 years worth of funding from the NIH to look at the impact of fatigue on diagnostic performance. And we did a whole variety of studies, from very basic type tasks or very simple tasks like finding nodules in chest images, all the way through more complex tasks like looking for different signs of trauma within CT images. And fatigue has an impact. We started out it's funny how we started out. When I run my eye tracking studies, I bring people into my lab, and typically it's over lunch, because that's when the radiologists are free. And I was noticing on a couple of them that, they came to my lab, and I was having trouble getting the signal that you need to record eye tracking. And so I looked more closely, and their eyes were drooping, and I was like, "You're falling asleep, dude. What's going on?" Just so exhausting. There's so many cases that we have to read and so on, that by noon it's just sometimes you're just exhausted and you're tired. And that got me thinking, okay, well, they're this tired by noon, and their eyes are drooping in my lab. What are they like in the clinic? And so that was sort of the inspiration for the first grant that we submitted. And we ended up getting funded, which was great. It was me and a colleague from the University of Iowa, Kevin Burbaum. And we were able to, like I said, sustain this for about 10 years, looking at the causes of fatigue and its impact. And we started out by seeing, can we find a physiological biomarker, in a sense, of being able to objectively measure fatigue? And so we said, okay, well, let's look at the eyes. That's the most likely place to look, because otherwise the answers could be subjective. Are you tired? Yeah, I'm tired. Okay, well, that's kind of subjective. And so we looked at a device that ophthalmologists use, an autorefractor, which basically tracks how well can you focus. Because if you think about when you're sitting in front of a computer or even in front of the TV, I guess, for hours on end, you lose your ability to focus. Your eyes get dry, you're blinking, you're moving back and forth, and sometimes you start to see double. And that's a hallmark of visual fatigue. And so, like I said, we talked to some ophthalmologists, and they said, an autorefractor, that's probably the best thing. And what we showed was that, indeed, by the end of only 8 hours, we were able to measure physiologically that radiologists and residents were less able to focus. And again, if you're less able to focus, how are you going to find fine details in an image? That then said, okay, we have an objective measure. We also had some subjective measures, rating, how fatigued are you, and so on. And then we said, okay, we've got objective measures, we've got subjective measures. Let's go into the lab and let's see if it has an impact. And through all these studies that we did in chest, in bone, CT, and so on, what we found was that and we typically studied people after only 8 hours. Now, I don't know many radiologists who only work for 8 hours. They're like 10, 12 hours. And so after only 8 hours, what we were finding was that there were statistically significant drops in diagnostic accuracy after only 8 hours of work, on average by about 5%. In the world of radiology, that's pretty big. And the changes were not just kind of shifting their criterion, they were actually getting more false negatives or misses, and they were getting more false positives. So both bad decisions were increasing. And we did eye tracking studies as well. And what we found with the eye tracking was their patterns would get, when you're fresh and you're on top of things, your patterns are very efficient. And you're finding things and you're kind of going through the image and you're seeing things coming and making decisions going up. When you got more and more fatigued, they kind of slowed down, kind of idled, looked around, took them longer to find things. Sometimes they didn't. Like I said, their errors went up and so on. So a lot of things change with fatigue, and it impacts diagnostic accuracy.
Like trying to read a book when you're tired and you end up reading that same paragraph over and over, and you're like, I've read this paragraph 4 times. I have no idea what it said.
Exactly, and that's exactly what it is. I've looked at this chest image 5 times. I don't have a clue. I got to go back again and see what's really there. Right. I'm going to gird my loins, and here I go, and you just can't do it. I mean, fatigue is fatigue. It's hard to push through it.
Yeah, absolutely. With that, are there environmental factors like lighting, equipment design, workspace ergonomics that can aid radiologists in improving their performance if they're fatigued? Honestly, even if they're feeling at their best?
Yeah, in general, I think ergonomics is absolutely critical. And I think as volumes have increased, as we went digital, I think this became even more critical, and radiologists started to realize it. When people were working with film, this is a long time ago, 35 years ago, I guess. When people were working with film, they would read a back, because someone from the film library would come in and put all these films on what we used to call a film alternator. And the radiologist would sit down, go through all those cases, and then they'd have to take a break because the film librarian would have to come, take them all down, put them back in the folders, and put up a new set. So there were built-in breaks. And you would have to, when you wanted to read the patient's history, you would have to look away from the images. You would look at the film, the information in the film folder, patient history, and so on you would have. And so your eyes were doing very different things with film. When we got into this digital environment, then people started to realize, it's more than just having the lights down low. Because we knew from film that you needed to have the lights in the reading room down low. I mean, you needed to dark adapt, and that was critical. But we didn't think that much about the chairs that people sat in, what the ambient light really has to be. We didn't think about noise or air conditioning and all these things. And over the years, I've studied a lot of factors, as have others, that have impacted performance. And what a lot of us started out with, I started out with, was looking at the monitors themselves. Film probably still is the best thing. It's got the best resolution. It doesn't have the same kind of contrast. But when we switched to monitors, there were a lot of concerns about that because especially 30 years ago, monitors were nowhere near what they are today. And so what we were looking at and the types of factors that did influence performance and, could make things worse, monitor brightness, monitor contrast, how you calibrate the monitor, pixel pitch and pixel size, whether or not you've got one big monitor, say like a 10 megapixel monitor, or 2 5 monitors side by side. You wouldn't think that that would make a difference, but it does. The ambient lights make a difference, and that interacts with the monitor. The chair you sit in, whether you're fatigued, whether you're hungry, how many interruptions you get. So yeah, the environment within which you operate and the tools that you have clearly impact diagnostic accuracy and efficiency. And over the years, what I found is that, sometimes it's more efficiency that matters, that sometimes diagnostic accuracy is not affected that much, but their efficiency is, they slow down. It takes them longer. And especially these days when radiologists are reading so many images, that often is far more frustrating and having an impact on people's well-being and burnout than being accurate. It's their efficiency. When it just takes so much time to get through things, when you're sitting in an uncomfortable chair that's making you, move around and change your position and this hurts and that hurts, that's going to impact everything. It's going to impact your speed as well as your efficacy.
This is maybe like a little bit of a non sequitur jump, but hearing you talk about this gets me and my mind thinking about telemedicine coming into the conversation, right? And so you have like your ergonomic environment where you're reading these images, but then you have like the larger structure around it, right? And so like there are unique challenges and opportunities for someone reading these images remotely. Do you think that, like, how does this differ psychologically from like a traditional in-person environment?
In two ways. One, your home environment, which is where, let's face it, that's where a lot of people who are reading remotely are. They're at home. You have to pay attention to all the things I just talked about. The ambient lighting. You can't sit in your living room with big, wide windows. It may be nice and comforting and psychologically
Sounds
great. It sounds great. Let me just let the light in. Well, letting the light in is not good for monitors. It can cause reflection. It changes the contrast. It does all sorts of stuff. It affects your perceptual system. So you've got to be able to truly replicate a good reading environment in your home environment. And that may not always be possible. And so, when we have people reading remotely, you got to talk to them and say, okay, ambient light's this. You can't have your dog and your kids running back and forth and, doing this. You got to create a space, a comfortable chair. Because what I've heard from a lot of people working at home is, they don't always take breaks. Possibly even more so than people in the real reading room, because you just you're in your little radiology cave and, you're just kind of there. Now, some people may take all their breaks, who knows, but I've heard that some people don't. And you kind of get into this, you start at 8 a.m. and next thing it's midnight and it's like, wow, okay, where did the day go? But you have to pay attention to the environment. And I think one of the things that reading remotely you miss out on, and it's a little harder to replicate, is just the social interaction. To me, I think that's important. You're not interacting really with residents in the same way. I mean, sometimes you're going to bring in the resident remotely, but they're over there on another monitor. Or they're just kind of, maybe they're on a cell phone, who knows, depending on how you're connected up. And it's not quite the same. And you're not interacting with other radiologists in the room. You can't really, stop a second and say, hey, Fred, can you come over here and take a look at this? And, well, what are your thoughts on this? You have to stop. You have to enter Teams or Zoom and say, no, you're free. And, it just gets more complicated. And I think people just don't do it. So, and that to me, that social part is potentially even more negative than all the environmental factors, because I think it truly does impact people and could potentially lead to burnout and fatigue as well as other things. It's very isolating, I think.
Yeah, I mean, it sounds incredibly isolating. I mean, I work from home a decent amount of the time. I'm in the office now. But yeah, I find myself honestly having way more bandwidth working in the office and having like a 2-minute sidebar with the person next to me, all of a sudden feeling significantly more refreshed rather than, once again, like home alone in my office, where I'm just like going and going and going. It's like, oh, I'll make my lunch. You know what? I'll just eat my lunch while I keep working.
It varies. I'm sure there are people who, and I know some teleradiologists or people who, and they do it fine. But there's others where I'm sure it's not as fun.
To keep pivoting a little bit while we're talking about like mistakes from a psychological level, I'm curious about radiologists' perception of risk and its influence on their decision making. So, for example, is there a tendency to be more cautious or conservative with like certain types of findings? And how might that affect the accuracy of the interpretations?
It's going to be an individual thing because everybody experiences risk in a different way. It's also going to differ as a function of the modality, the specialty that you're in. For example, breast imaging. If a radiologist, calls something and, it's going to require follow-up and a biopsy and so on. Yes, getting a biopsy, an ultrasound or an MRI, some kind of follow-up exam, it is impactful on the patient and so on. But if I'm reading a chest image and recommending a biopsy, that's potentially a lot more invasive than a breast biopsy. A breast biopsy is not going in through the lungs and risking a pneumothorax. So, every decision has its consequences. And I think, yes, everybody is aware of what those consequences could be. And to some extent, I think that guides people's willingness and unwillingness to call something, especially in, sort of that middle range of, if it's obviously there or obviously not there, people are happy. It's always the funny ones in the middle that, what do I do now? Now, what do I recommend? And in some cases, it's easy to recommend, okay, let's do this follow-up. In other cases, like I said, it's not that easy of a decision. And on top of that, let's face it, the United States is a litigious society. And so that's always a possibility in the back of people's minds, too. If I call this and it's a false positive, am I going to get sued? If I don't call this and it truly is something, it's a false negative, am I going to be sued?
Am I going to get sued?
It's got to impact people's decisions. And, it's kind of interesting that you can go from one practice to another. And there's sort of a culture of an institution. And people start to recognize what's acceptable in that institution versus another institution. And it's not like saying that, once it's an institution, they're going to call everybody back and another one not. But, there's fine levels of differences. And you kind of got to get used to what's the culture there. And you can go to any radiology department in any division and ask, okay, who calls back people the most? Who's more conservative and who's more liberal? Everybody will know. The techs will know. All the other radiologists will know. So everybody has their own thresholds. And I think that is a reflection of risk. Does it contribute to errors? Everything contributes to errors. Nobody's perfect. And unfortunately, our legal systems rarely recognize that. There's an expectations that, physicians and radiologists are going to be perfect. And simply not. Some things you're going to miss, and there's going to be a variety of reasons for that. It's one of those things that's always in the back of people's heads, and it can influence some decisions, but I don't think it's like a driving force that's, what's at the front of everybody's minds when they're making decisions. Radiologists really are out there trying to do their best to find what's going on with the patient and to be able to convey that information to the other providers and, be involved in the diagnostic process so they can, have the best outcomes for the patients. And risks are there, but, it's just a fact of life.
Yeah, absolutely. Are there training techniques or approaches that you think could help reduce error?
I think that's what the whole training process is all about.
Yeah, absolutely, right? But based on your research, are there specifics that get you excited?
I think the whole concept of personalized training, there's folks that are looking at ways. In the normal clinical situation, you're not going to encounter every single possible disease at a high enough volume. So what some people are doing is creating test sets. And I have one colleague, Lonnie Sakowski at the University of Wisconsin, who's looking at breast imaging. And what she's doing is creating sort of an AI-aided system where the trainees go in, the residents go in, they read sets of images, and the AI, in a sense, says, okay, they're really good at masses. You don't need to see those anymore. let's concentrate on microcalcifications or, asymmetry. And it will then adjust the type of training that this person is getting. And these are things that she's hoping people will, she'll get this system up and running and people will do in their spare time to augment the training that they're doing in the clinic. And what she's finding is that, the residents love it because it is giving him, one, exposure to different types of cases, and two, immediate feedback. She's using cases that are already path proven. In the clinic, you rarely get that immediate feedback. You're right, you're wrong. That doesn't happen. Whereas this type of training where you do get that immediate feedback and you start to learn, here's my weaknesses, here's my strengths, maybe I need to work on my weaknesses a little bit more. That's the type of training that I think can really help. And these days when you can augment it with AI and help AI kind of figure these things out, I think that's sort of a really cool direction that we're going in.
Yeah, absolutely. I mean, I've been talking with so many folks about the way that AI is coming into play in imaging in general and high level stuff, getting down into the nitty gritty stuff. But no, this is the first time I've heard someone talk about using it as a qualitative training tool, specifically in helping folks identify their own strengths and weaknesses rather than these larger conversations. It's really cool as just a qualitative training tool. Dr. Krupinski, radiologists are often facing incredibly tight time constraints and high pressure situations. How does the pressure of time impact their cognitive load and decision-making accuracy?
I think it's going to depend on the individual. You've got the people who, I thrive on deadlines and, put me under pressure and stress. I just excel. And there are some people that works for. And then there's others that, no, that's not going to work. And, they just kind of fall apart. So I think to some extent it is an individual thing. But overall, I think it is leading to potentially more errors. I mean, there literally is only so much an individual can do effectively. And when you think about, especially some of these, CT and MRI cases, or when you start to fuse PET MRI and PET CT and you've got multimodality imaging and you've got, patients with long histories and you've got to go into the patient record to sometimes figure out what's going on. All of these things contribute to the pressures that the radiologists are feeling. And yes, it undoubtedly is going to lead to errors. Whether you can trace things back and document, yes, this occurred because of this, that's a little less straightforward. I mean, there's, correlation does not equal causation. But clearly, I think that there are increases in all of the factors these days that could lead to potentially to more errors. But on the other side, there are also a lot of efforts going into ways to figure out how to reduce those errors, whether it's through AI, whether it's through optimizing the environment, whether it's through looking at different countries where they do double reading, for example. There are strategies and we are looking at them. So is it a doomsday thing that, radiologists are under all these pressures? No, it's not. And they've faced them over the years. They will continue to face them. And their jobs will continue to evolve, and the types of tools that they incorporate into their workflow in order to ameliorate some of these errors and address some of these things, that's going to change too. And, it's going to evolve. And I think it's not something that's negative. It's something that's very positive because we're acknowledging that things are changing and we have to change other things as well in order to keep the radiologists at the top of their game.
Yeah, absolutely. And with that, Dr. Krupinski, I want to thank you so much for having this first half of the conversation with me and a little peek for our listeners. Dr. Krupinski and I will actually be continuing our conversation in a part 2, specifically getting a little bit deeper into radiologist burnout and its scientific underpinnings. So please join us for our next episode where we will continue this conversation.
Frame by Frame Rethink Imaging is brought to you by Emory. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Emory is rethinking imaging in healthcare, visit Emory.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, Google Podcasts, or wherever you listen. And from all of us here at Emory, thanks for tuning in.